Hi, welcome back to Raaonline. Today the topic is about cysts. We did talk about the classification of cysts, WHO's classifications in entirety. So today I'm going to be completing the remaining of the cysts that we did not deal with last time. So the first and the foremost is your eruption cyst, got from the reduced enamel epithelium. It is mostly associated with the primary molars, occasionally the incisors, okay? You will have a 7-year-old or an 8-year-old or even a 10-year-old coming to you saying it's very painful. You look into the mouth and you think, for most of the time you think, oh my God, caries, something problem, blah, blah, blah. But you go inside and you find, aha, there is a swelling on the soft tissue on the erupting tooth. So that's your eruption cyst, okay? Very often the first molars, the canines present as eruption cyst. So ruptures, it comes spontaneously, it goes off spontaneously, and you give them antibiotics and painkillers and it subsides pretty well because it is lined by a very thin stratified unkeratinized squamous epithelium. And then if the tooth is coming through, but if the primary dentition is there, then it is going to be a problem. But if you take away the primary dentition, then the eruption is going to be no issues at all. So we've done with the residual, with the radicular, where are we? The radicular, residual we've done. We'll move on. The eruption is okay. We'll move on to the other kinds of cyst. Dentigerous cyst. Now, dentigerous cyst is an important dentigerous, odontogenic keratocyst, and an ameloblastoma or an adenomatoid odontogenic tumor. These are things that are your differential diagnosis that comes in your mind if you find any lesion in the angle of the mouth. Okay, ameloblastoma, if it is a huge cystic lesion, single locule, you're thinking of an unicystic ameloblastoma. If you're thinking of a multiple loculated lesion, then you're not even thinking of any kind of cyst. You straight away go with a multilocular, you go with ameloblastoma. You do not think of cyst. But then saying that, we do know an odontogenic keratosis OKC or a KCOT, which was called previously, or a dentigerous cyst, do have a percentage of transforming into ameloblastoma, provided the patient has left it for a long period of time. All right. Okay. So the dentigerous cyst, when you're looking at it, usually it involves an impacted tooth which is buried inside, and the cyst develops around the tooth that is impacted, around the cemento-enamel junction of the impacted tooth. So the epithelial lining is obviously stratified squamous epithelium of varying thickness depending upon the tooth that is involved. If it is in the anterior region, it is much more thinner, but if it is located in the posterior region, then it is much more thicker, saying that there is a lot of variation. There is no one-stop solution. There is no one-stop definition or presentation that is available. Variations of presentations are available with this kind of a cyst. So you need to be very careful when looking at a radiolucent lesion, which is especially involving the angle of the mandible. Connective tissue may be very little, minimal or inflammatory in nature. So if I'm finding that the patient has a huge, swelling, and I find clinically, I'm examining the patient, I'm looking at the patient thinking there's a swelling here in relation to the 8, the tooth is buried, the tissues are a bit inflamed, and then I think, okay, let me put the patient on antibiotics. But before that, I think I must investigate, I must see what it is, and I take an X-ray. So when I take an OPG, then I look at the presentation of the OPG, I see a huge cystic lesion here. This is very minimal, okay? This is just a representation of how a dentigerous cyst will be, okay? Then I think, what is my next line of treatment, next line of approach to this patient? I go about doing a fine needle aspiration cytology, wherein I palpate the bony tissue around over the impacted tooth. I look for the bone crackling if it is present. I look for the weakest point of the bone, and then I insert my wide bore green needle, wide bore needle into the bone, and I try to aspirate the contents. Fine needle aspiration cytology. When I aspirate, I find thin straw colored fluid. Bingo, I have my dentigerous cyst. Okay. Now, this is a tricky scenario. Now, when I talk to you and I say, as though it will be an impacted tooth, it will be around the crown of the tooth. Look at this. Now, do you think is that a radicular cyst or a dentigerous cyst or what, or a nasopalatine? Nasopalatine is a bit more onto the lateral here. It's not in the center, so it can't be nasopalatine. So I'm eliminating nasopalatine. How can I eliminate dentigerous or the radicular? Well, it is involving the roots of these teeth, especially the lateral here. It is also involving this. This tooth seemed to be involved at the apex on the other side as well, onto the mesial side as well. And I'm also finding, there is widening of the periodontal ligament space here, well-defined, very well-defined radiolucency. And I also see an impacted canine. So I'm thinking, if I am going to be a student who's just read about dentigerous, the one thing that will strike my mind is impacted tooth, dentigerous cyst. Hello, impacted tooth, dentigerous cyst, but then where is the cemento-enamel junction? Is the cyst abutting the entire tooth here? Is it involving? Is it centrally placed? Is it laterally placed? But whatever it is, does it involve this tooth on the other side? This is the labial aspect of the canine there, and this is the palatal aspect. The labial aspect does not seem to be involved at all. So I am eliminating dentigerous cyst. That is a radicular cyst.